Hi everyone, welcome back to our last session of the day. I'm Sarah Hardy, Senior Strategy and Programme Manager at the Health Foundation. Today we're talking about large-scale programmes in healthcare. These are also known as national programmes. As we're about to hear, designing and implementing these programmes is really critical but very complex. This institute, alongside the Health Foundation, have designed a framework to improve the early stages of the design of these national programmes. I'm excited to have been involved in this important project from the start, so it's great to be able to share the outcomes with you today. Our speakers will outline what national programmes are and how they're used by policymakers, before moving on to talk about the insights from the project and the framework itself. We've got lots of time for questions after these videos, so please remember to use the question and answer functions. In the videos, we're going to hear in turn from Charles Tallack, who was the Director of Research and Analysis at the Health Foundation until September. He then stepped back and is now Senior Fellow. Charles will outline the national programmes and the role of this framework in that. Then we'll hear from Abbie, Greig, Research Associate at this institute, who will talk through the evidence base that the framework draws on. Then we'll hear from Jo Scott, Associate Director at Ipsos UK. Jo will talk about the insight from stakeholder interviews on how healthcare differs from other large-scale programmes. And finally, we'll hear from Mary Dixon-Woods, Director at this institute, who will present the framework itself and how it can be used. All right, let's get started with those videos now.
The NHS is a national institution accountable to ministers. Ministers and national policymakers will always want to make improvements for patients and staff through changing service models, for example. National programmes are an important part of the toolkit that they've got to secure large-scale improvement. National programmes typically involve edicts, guidance, incentives, performance management, evaluation, and soft forms of influence, winning people's hearts and minds, for example. There are various examples of national programmes. One of the most successful ones of the last couple of decades has been 18 Weeks programme in the early 2000s. More recently, there's been an NHS England cancer programme aimed at earlier diagnosis. There's integration programmes, the Pioneers, integrated care pilots from the 2010s, pharmacy integration, social prescribing, new care models, virtual wards. I could go on. But these programmes have not been uniformly successful. The past is littered with the names of national programmes, but there's little trace of their effects. This project aims to improve national programmes by providing a framework and guidance. National programmes will continue to be an important part of delivering, including the 10-year plan. And that's why we think this is important. So the genesis of this project, we need to go back to the Simon Stevens era in NHS England. My team, I was head of evaluation, worked with several programme teams evaluating national programmes, and we observed and formulated ideas for improvement. There was no real appetite for those ideas in NHS England, but at the Health Foundation, those ideas have been developing and have been built upon by our work with national programmes evaluating those here. We've seen the programmes making the same mistakes, and there's a nagging thought, which is that we could do better, and that's what spawned this project. So what were my formative experiences at NHS England? We need to go back to the 5-year forward view, and one of the big ideas in there was the new care models. Two most ambitious and popular of those new care models were two models, the MCP and PACS models, aimed at creating new types of integrated care providers. 23 vanguards were responsible for developing those. It was a well-resourced programme. Hundreds of millions of pounds went to the vanguards. There was a very generous national support offer, helping the vanguards with various aspects, workforce, communications, contracting, commissioning. Simon Stevens was in charge. NHS England had a lot of freedom, and there was very little interference or accountability. So all the conditions were there for success, but was it a success? Well, NHS England stopped funding the vanguards after 3 years. The MCP and PACS vanguards, the 23 of those, hadn't delivered. There was some evidence that they'd slowed growth in emergency admissions, but there were no new provider forms, there were no changes to CCG contracting, and today there is no real observable legacy of those models. There are multiple problems with that programme but to pick a couple. The first was unrealistic timescales and expectations. These led to rush thinking and planning and poor decisions. But there was also too little time to allow these quite complex models to develop. The second problem was the lack of clear thinking about objectives and the theory of change. Was the aim really about reducing emergency admissions, or was it something else? And how precisely would they achieve that? There was no real serious attempt to learn from the evidence about what had worked in the past and to test specific changes to fill the gaps. Since New Chemicals, there have been numerous other programs. Few of them, I would say, have succeeded. One example is the virtual wards program, which is still ongoing. That has not delivered its objectives. There are far fewer beds than envisaged, and there are multiple forms of models, and no one knows quite what works. So in summary, national programs are here to stay. Few to date have succeeded. However, there are examples of successes, so we know they can work. And in those that haven't, there's plenty of room for improvement. We need an evidence-based, systematic approach, and that is what this project is delivering.
Hello, my name is Abbie, and I am a research associate at this institute. Today, I'm going to talk to you about the lessons we have learned from looking at the literature that will help improve how large-scale healthcare programs are planned and designed. We have looked at literature from many different sectors and from government guidance to identify learnings relevant to complex major programs in healthcare. Much of this literature falls under the rubric of mega projects, which refers to projects characterized by their large size, complexity, and duration. We also looked at guidance produced by the UK government on programme planning and delivery and managing successful projects. And finally, we looked at literature evaluating large-scale programmes in the health sector, which are not typically classified as megaprojects, but nevertheless are characterised by distinctive complexities. Evidence from across this literature shows that large-scale projects often suffer from the same challenges and problems, regardless of their sector. But despite such shared challenges, these bodies of literature have largely evolved separately from one another. So we wanted to synthesize these learnings and explore what we can learn from past large-scale programs that can help inform guidance for programs moving forward. In the next few slides, I'm going to draw out some of the key problems and common failings noted throughout the megaprojects and large-scale programs literature. Perhaps the biggest problem raised throughout the literature is optimism bias, or the tendency to overestimate the likelihood of positive outcomes and underestimate the chance of negative outcomes. This can result in underperformance in intended cost, schedule, outcomes, and impact. A prominent example here is the National Programme for IT, which was launched in 2002 and had the goal of reforming how the NHS in England uses information to improve services and patient care. However, the programme was dismantled in 2011, having achieved very little while running up substantial costs. Weak leadership was also cited as a common problem, with projects often being led by managers without any specific domain experience and who may regularly change throughout the project lifecycle. This can be a particular problem for large-scale health programs as they are inherently political. So changes in leadership and vision across electoral cycles can have a big impact. Weak leadership can also fail to foster a collective vision and establish shared goals amongst stakeholders. Related to this, large-scale projects often involve multiple diverse stakeholders who are likely to have conflicting interests, and this presents challenges for decision-making, planning, and management. For example, in large-scale health programs, there may be tensions between the views of professional bodies, clinicians, the government, and patients and the public. A further key challenge noted in the literature is that there is often inadequate definition of roles and responsibilities. This creates a lack of direction and enables stakeholders to transfer risk onto suppliers and delivery partners. If we look at health programs, there may be confusion, for example, regarding whether responsibility lies with an individual trust or with the wider team overseeing the national project. The literature also raises the problem of projects locking in. This refers to an overcommitment to certain concepts or elements at an early stage of the project, resulting in weak analysis of alternative solutions and a lack of flexibility as the project evolves. And finally, a challenge that is particularly relevant to healthcare is poor community engagement. Often, there is a lack of clear and consistent engagement and communication with the population who will be affected by the programme, such as patients and carers. For example, the Care Data Programme, introduced in 2013, aimed to enable data sharing for research and service planning, but was discontinued 3 years later following widespread public concern regarding privacy. So the literature shows that there are many challenges and complexities to designing and delivering successful large-scale programs. In particular, we found that many of these challenges stem from decisions made at the outset of project development, and that guidance is therefore needed for the front end or early planning stage of a program. If this early planning stage is done right, it can have enduring effects throughout the project lifecycle. It is for this reason we designed a framework that focuses on the very early stages of planning a large-scale health program, which we look forward to discussing later in the session.
Hi, my name is Jo. I work in the Health and Care Evaluation and Advisory team at Ipsos. So we've been working collaboratively with the Health Foundation and this institute to explore what does good look like when designing complex national change programs in healthcare. So national programs are used for making large-scale improvements, although they can be complex and not always successful. This project aimed to develop guidance for designing and delivering health programs. We combined a literature review with insights from 17 senior leaders with hands-on experience. Today, I'll share findings from these interviews, which provided a wealth of insights to inform the development of practical guidance. So first, we have to understand how the healthcare sector differs from other fields and why existing guidance might miss some of the nuances of this context. So it's highly politicised. So healthcare is always a top issue for voters, which means that programmes face intense scrutiny and pressure for quick, visible results. Power is distributed, which means that programme leaders must navigate a maze of stakeholders with competing interests and level of influence, from different NHS organisations and local authorities to patient groups, professional unions and regulators. And professional hierarchies are strong. The culture of healthcare is influenced by clinical hierarchies and managerial hierarchies between different decision-making organisations, which can create unique power dynamics and resistance to change. And the scale of spending on healthcare is immense. This attracts constant focus from the Treasury, adding another layer of pressure and oversight. So this combination results in a highly complex context with high levels of uncertainty and scrutiny. But health and care leaders manage this complexity daily. And based on what we've heard, we've identified 5 themes important for shaping programme design, which I'll speak through in turn. So firstly, to navigate the political environment. You can't fight it, so you have to work with it. What we heard is that successful leaders create a unifying vision that politicians can support, but that also resonates with frontline staff. They become masters of translation or performers, managing the tension between politicians' expectations and the operational realities on the ground. It's important to define the problem before the solution. This was the strongest message from the interviews. Too often there is a rush to implement shiny new solution without deeply understanding the problem. So this requires taking time to explore the issue from every angle before you get to a solution, and recognition that there needs to be boundaries on what the programme will and will not address. Third, it's about finding a way through that stakeholder maze. With power so widely distributed, stakeholder engagement can't be a tick box exercise. It requires sophisticated strategies to understand who holds influence, what truly motivates them, how to build networks for both formal and informal learning and exchange. As one leader said, you might talk about oranges and apples and pears to the Treasury, but fruit salads and trifles to the NHS. You have to translate and speak different languages. And fourth is about using a mix of levers. So there's no one magic bullet. So programmes have to use a combination of strategies. This includes hard levers like funding, regulation, and performance management, but also soft levers like influencing hearts and minds, fostering peer-to-peer learning, using evaluation to learn and adapt, not just to prove success retrospectively. And adaptive leadership is essential. The interviewees describe leaders who can hold contradictions. They must be open to input but decisive, a connector and interpreter, but also willing to challenge. They must be politically astute whilst remaining grounded in operational realities. So there's no single winning formula. Interviewees were very clear on that. The landscape is too complex and unpredictable for that. But by understanding the unique context of healthcare, embedding these 5 principles, what we've heard suggests that this will improve programme design. So our contribution is to a comprehensive, user-friendly framework. We've been testing it with teams so that we can ensure it is a practical tool and we can turn these insights into really tangible guidance. So you can scan the QR code to read the report that shares the findings from these interviews, and go to the This Institute website for more information and to download the guidance.
Hello there, and I'm delighted to be part of this session presenting our framework to guide early planning of large-scale change programmes in health and healthcare. This has been a great project, and our aim was to co-design practical guidance in the form of a framework to guide effective design and planning, what's often known as the front end of programmes. As you've heard from Abbie, we started with a literature review, and that synthesised evidence from government guidance, from national audit reports, the huge literature on mega projects, and the even huger literature on big programmes in the NHS. You've also heard from Joe, who's giving us an excellent overview of the interviews that Ipsos did with stakeholders. And if you have a chance, it's really well worth looking at their report. It's full of really fascinating findings. Once those 2 stages of the project were complete, we developed an initial version of the framework, and we went out to consultation. We did that using a survey and think aloud interviews, where we asked people to think through that early version of the framework and give us their feedback on whether it would work for them. We learned from that and produced another version of the framework, which we then took into a simulation. This was an absolutely fascinating event involving a tabletop exercise with 5 real policy teams with real questions they needed to answer, and they tested using the framework in practice. That has led us to the final version of the framework, which we're very, very excited about. And this is a framework to guide early planning, what's often known as the front end of large-scale change programmes in health and healthcare. The framework offers guidance on how to use it, and it offers much flexibility in this depending on your needs when you're planning a programme. It offers a quick overview, a framework at a glance, and then it offers a series of structured questions. The idea is that those questions can be used collaboratively, dynamically, and flexibly, depending on where you are with your project and the needs of your team. And those questions are supported by evidence about what good looks like and illustrative quotations from the interviews that I mentioned earlier. The framework in full is organised into 3 sections. They cover programme purpose and content, context, stakeholders and implementation strategy, and then the really vital stuff on programme management, costing and scheduling, governance and learning. It's intended to be used iteratively and flexibly as part of conversations in the very early stages of planning a programme. The framework at a glance then takes you through a number of questions relating to each of those 3 topics. And you don't need to use these necessarily rigidly or in sequence. You can move around quite flexibly. The framework for each question offers a series of both a core question and then a series of questions that will help you in answering that core question. It offers you some ideas about what good would look like, and it gives you those illustrative quotations. So we hope this is going to be really, really useful and practical for teams as they try to figure out what are the range of things they need to think about and make sure that they've got them covered. So this framework brings together a large body of guidance and literature that's out there on how to run big complex programs, which include everything from tech adoption to long-standing challenges in health and healthcare. That literature tells us that getting that front end right is crucial. the decisions made at the start have enduring effects. And this structured framework is bringing all of that together. It may help with directing attention towards key considerations and is likely to be especially useful if it's used in dialogue. Thank you.
Hi everyone, welcome back. We hope you found those videos insightful. So here on the panel today, I have Charles Tallack and Mary Dixon-Woods, who you've just heard from on those videos. We're also joined by Michael Lawrie, Director at Ipsos UK, and Ron Agble, who is Improvement and Transformation Advisor, currently working at this institute. We are kicking off with questions from the audience. So if you have a question for one member or all of our panel, please drop it into the Q&A box now. We'll be getting through as many of these as we can. So first question, and Mary, I'm going to come to you to start with this one. We've had a question which is the success of large-scale programmes mostly in the hands of those delivering them or those commissioning them, including politicians?
Thanks very much. What an interesting question. I would say that these big programs are multi-stakeholder projects and there are many hands involved, and it's often context specific who has most responsibility. The framework that you've just heard us talk about was designed to focus specifically on the very, very early stages of planning and designing programs. And that's the point where I think you can begin to figure out who is responsible for which parts of design, of delivery, and so on. And at that point, aliquot out the responsibilities. So I'm not sure it's going to be possible ever to say it's this group or that group who are responsible. But I think one of the things we did learn about, and Mike will probably say more about this, is the very profound influence of the political context in which these programmes are delivered and how that can be both positive and negative. Thank you.
That's really helpful. Mike, would you like to come in on that?
Yeah, we've got a quote from the research that captures this question, or captures and answers this question. So we heard from senior programme leads, and one said to us, it's the triangle between the Treasury, the minister in question, and then the programme team. That's where the decision making happens. So obviously the Treasury represents the sort of economic question mark. The minister represents the political drive. The programme incorporates in healthcare the health service managers, the clinicians, the patient voice. So I think that's a nice triangle to capture the various influences on this.
Great, thank you. Moving on to learning from failure. Charles, why is learning from failure, why is learning from previous failures such a challenge in the NHS? Do you see mistakes being repeated? And if so, why do you think that is?
Thanks, Sarah. Again, that's a really interesting question. It's quite a big question as well. And I think I personally, having seen national programmes across many years, see the same sort of failures being repeated, or at least I would say there's no great improvement in the success factor of national programmes. And they may be failing for different reasons, but I think, that's what some of this framework was trying to address, which is bring some consistency so that we don't fail in the same sort of ways. Why? I think, why do we see this? I think it's, well, personally, I would say partly there is because there's a lack of a framework for how to do these things, and that's what's really helpful about this. The other thing is tied up with what Mike says about the politics of all this. And I think people, again, having seen some programs close up, I think people find it actually quite difficult to admit that some of these programs aren't succeeding in the way. And you do also see something about sometimes the goalposts have moved. So programs are said to be successful, even though they've achieved a set of objectives which weren't there at the outset. They've kind of moved the goalposts. So actually, this is all about patient satisfaction when it wasn't. It was about, reducing admissions to hospital or something like that.
Yeah, that's really interesting to reflect on. Ron, I wondered if I could bring you in here to talk about your experience, particularly around targets as well.
Yeah, sure. Thank you, Sarah. And I might just comment a little bit on the previous question as well. This question about in whose hands does success or failure lie? I think the simple answer is it's both. And I think you can have strong central support for programs, and we've seen this in some cases, and that's necessary, but on its own insufficient. because you can easily have programs where there's strong central support, where actually you don't have the delivery system really pulling in the same direction. And then actually what we just have is an empty policy commitment. And we've seen a few of those over the years. On the other hand, we do have programs, and I've worked on one of them that I might talk about a little bit more later, where you have quite strong support within the delivery system. Perhaps we started out with strong political support and that goes. So you can end up with these slightly orphaned programs as well, where those in the delivery system are still pulling quite hard, but are looking for someone in the centre to be sponsoring and making sure that there's funding. So we need both, is the simple answer to that, which I don't think will surprise many people. So the actual question you put to me, this question about why do we not learn rigorously the lessons from success or from failure? I think there are two potential deficits here. One is a deficit of knowing, and the second is a deficit of doing. I think in terms of the deficit of knowing, we have had plenty guidance over the years, and I think the document produced by the Institute is an incredibly helpful addition to that provides a guide as to how can you do things. So I think in some cases there might be a deficit of knowing, but I think the far more significant and prevalent deficit is a deficit of doing. Why don't we do the things that we know we should do? Again, I don't want to give too many pithy answers this afternoon. The reason why we don't is because it's difficult. And there's a saying I'm quite fond of. I might mispronounce the originator of this saying. It's one of the Greek philosophers, Archilochus, I think. It's been adapted by many over the years, so plenty of people have taken credit for it since. I went along the lines of, we don't rise to the level of our ambition, we fall to the level of our systems and habits. And I think that explains quite a bit here. So what systems and habits do we have in place to enable us to stick to the guidance so we end up doing the things we should do rather than things that are difficult to do, or easy to avoid. So I think that's how I'd put this. I think there's a deficit of doing, and I think when we can systematize guidance like this, we'll be in a better place to make sure that we're more likely to do the things that we should do. And of course, all the other things pertain. We need great leadership. We need courageous leadership. We need people to be able to say, hang on a sec, can I just challenge that? Because we should be doing something here that we aren't. And I think the more exposed and the more people we get involved in that process, the more likely we are to adhere to the things we should be doing. That helps.
That's great. And love the idea of falling to the level of our system and habits, and hopefully this framework is one of the ways of levelling up those systems and habits. Mary, can I come to you to ask your reflections on the centre versus the delivery and how the framework moves us forward with that?
Thanks very much. The framework is intended essentially for the team that is charged with coming up with how the programme is going to operate in practice. It's focused at the very, very early design and planning stages, and it seeks to get those teams to work through systematically a set of questions, including, what's the purpose of the programme? What's the case for change? Is the large-scale programme the right approach? And it also crucially asks about context, stakeholders, implementation strategy. And I think that's where the point about the link between the centre and delivery will be discussed and debated within that team. And our framework is not really providing any answers, but it is saying these are the questions you need to ask. And it's giving examples about what good looks like. Where I think where you run into problems, and Ron has already begun to tease this out, is when you don't have clarity about what is the balance between centre and delivery, who gets to call the shots, who's ultimately responsible, who in fact is going to claim the credit if it does work at the end of the day. So I would say the framework doesn't resolve it, but it does make you answer the question that will help you then be explicit about it.
That's great, thank you. And hopefully we can dig into those questions of ownership and who's answerable for these a little bit later. I'm going to move us on to talk about a question of influence and power. So Mike, coming to you to ask, how do you challenge programmes that are being proposed by high influence, high power individuals, but where the priority is not for the organisation based on data? What are your thoughts?
So, this is going to be a shout out for some good old fashioned structures and civil service values and the art of analysis in moderating different viewpoints and so on. So I say this from a perspective at Ipsos. We work across every department of government, so we see different evidence cultures in different policy areas. And certainly when we work with civil service customers, we are more often not walking through a process that they've been through. So they've been through the policy generation, the appraisal of those options, long lists down to short lists, the economists weighing up the different return on or the different value for money ratios and so on. So there's a set of structures, traditions that are, to my mind, are really, really well cemented into processes there. Sometimes I think it perhaps is less evident in the health and care world when we're doing those evaluations there. That's not to say those processes are not there at all. And of course, there are incredibly strong moderating influences in the form of NICE and obviously the Secretary of State, the Department of Health and Care, so on. But that's just an observation. So look beyond the health world to understand the forces of moderating influence. But just to slightly turn the question on its head as well a little bit, the research we did really did point to the value of the leader, the iconoclastic individual, sometimes someone open to input but decisive, a connector, interpreter but willing to be challenged, political astuteness, and then a creator and leader of teams. So we did find a whole body of work there that these qualities are necessary as well to drive forward the good programs.
Yeah, that's really interesting, isn't it? The tension between leadership, creative, engaged, that pushes programs forward, and the leadership which maybe isn't data-driven or isn't recognizing the challenges and how that can hold programs back. Mary, can I come to you to talk about some of the solutions that are being proposed? Why does the NHS so often leap to attractive, popular solutions without thoroughly understanding the problem first?
I am very happy to be asked this question because I am very keen that the problem is fully understood before you rush to a solution. And it's absolutely true that something that comes along that appears to be a solution, but it's not really clear what is the problem it's trying to solve. And that's the wrong way around. And we see it at every level, from local quality improvement all the way up to these big programs. And it was very interesting listening to Carolyn Johnston's analysis a bit earlier. And she was talking about, a clinical pathway and why is it so difficult to get the patient from the door of the emergency department into the operating theatre when they need an emergency laparotomy. And she had to do months of work to figure out what the problems were. And had she gone straight for a solution, then it's quite possible it would have been targeting the wrong question. But we've seen multiple large-scale solutions which start with the solution and then they're trying to figure out how to get it to work. And it may be that it works in some places but not others. A recent example is virtual wards, where we saw a huge program with an awful lot of backing go large. And it was very successful in some areas, but much less successful when it came to others. For example, frailty virtual wards saw very little uptake of technology, and that was because the tech solution was pushed before the problem that the clinicians and the patients and their carers were trying to solve was fully understood. So I'm a great believer in figuring out what the problem is first, and then tailoring your solution accordingly. I think we skip that stage because it's much more attractive to move straight to action. It's much more politically convincing to say we already have the solution, but it's a terrible mistake. And part of our framework is really emphasizing get your understanding of the problem right first, from multiple perspectives, because there's rarely one understanding of the solution and only then, one understanding of the problem and only then move to the solution.
Really useful.
Yeah.
Thanks. Ron, would you like to come?
Yeah, thank you. And just building on Mary, it's an interesting question. I mean, for me, one of the things about the question I spotted. So what do we mean by the NHS in the context of this question? because I think there are at least three potential layers, and goodness knows there are many on the call who would prescribe maybe more layers than this, but there's a political layer, I think there's a civil service layer, and I think there's the NHS providers and commissioners. And if we look at those three separate layers, my experience is that the NHS, in terms of providers and commissioners, are often quite circumspect about the latest new thing and require a certain burden of evidence, academically informed and so on. I think as we move up the layers, I think there's maybe more pressure to come up with solutions very quickly. And I think in our 24-hour news cycle, really, I mean, someone can be on a phone in and be asked a question and they need to provide a solution maybe 10 or 15 seconds later. It hasn't always been this way, but it's my observation that it is that way now. So I think we just need to be cognizant. This isn't me sitting and saying it's really easy. Politicians should just chill and give it a few months for someone to come up with a solution. I think it's recognizing there are different pressures on different stakeholders within the system. And in order for us to move forward, we have to acknowledge that and find a way to come to the right solution, which starts with understanding the problem well, but along timelines that work from an evidence perspective, not necessarily from a kind of Twitter perspective, if I might frame it like that, or X, I think it's called now.
That is really helpful, and it's interesting to think about those different layers of evidence and the multiple perspectives that might get you to different answers, even when looking at the same problems. Sort of building on that, the next question, Charles, I'm going to come to you. Why has the art and science of programme or policy development and implementation not been sufficiently recognised to date? And how can we get support for this as skilled work that takes time and resource?
Thanks, Sarah. So I've particularly focused on the art and science of policy development, which I think links to what Mary was talking about the kind of upfront thinking about, well, I guess, you know, the case for change, the rationale, the problem definition, what is the actual problem here? I mean, all of that takes time. So I would say there is an impatience there. You know, people want to get, rightly, they want to get on and improve things. I would also say that, and this may be controversial, but I would say that the NHS puts a lot of emphasis on delivery. You hear that word all the time, and you see it in like the dashboards that are producing. It's all about, you know, how are we delivering things? But there's not that much, I will relatively less emphasis on, are we delivering the right things? Like, is it effective? Is what we're proposing, is the problem definition right? And I think the culture of delivery, getting on and doing, you know, getting on and doing something is quite strong there. So I would say it is to do with actually really making sure that we value the kind of policy development skills. Mike also made this point about actually some of the things which apply when I was a civil servant, which applied there about, you know, of course, the civil servants are not immune to having programs that don't work, but some of the discipline that comes from doing impact assessments, having to actually convince the Treasury of some of these things which actually the NHS doesn't have to do in the same way. I found that quite shocking when I joined NHS England, that lots of the kind of, you know, and some people see them as like, you know, barriers, hurdles, but actually those things that you had to do, just the absence. It's quite possible to get a multi-million pound, £100 million programme up and running without having to really explain why this is value for money. What are the objectives you're trying to achieve? What are the options for achieving those? And what's the most effective and cost effective of those?
Sarah, would you like me to?
Yeah, please do.
Yeah, I mean, it's a thought-provoking question. I would like to begin again. I'm sort of sitting here in a private sector company that delivers services across government of the NHS. We get asked by government to do evaluations. We get asked to do economic work for government and the NHS. We get asked to do social research projects for the NHS. We don't often get asked to go in to work directly with civil service or health policy teams. It's one of the most sort of, I think, sort of highly thought of parts of the government. They don't commission out lots of work. It's a revered profession within the civil service as well. So I think probably there is a great deal of art and science and good quality civil service work going on in policy work, in that policy profession within the civil service. So it's not to sort of question the premise of the question, but to sort of say that it's a strong profession already. So that's my response there, Sarah.
Great, thank you. And I think there's something important there about the different pressures that people are on, which leads us on to our next question. So Ron, coming to you, is there an issue where only projects with an optimism bias get support and funding while realistic projects are not favoured?
Slightly leading question. So where do I sit on this one? So there are some well-used processes for approving cases of any sort in government. We used to have Green Book, things like that. Let's have a look at the kinds of information that lead to a project more likely going through than not. There's something about scale of impact. For me, there's also something about cost. There's also something about likelihood of impact. Now, if we just play the thought experiment where there's a project on one hand that has the potential for large-scale impact that is of the same cost of another project that is maybe has a greater likelihood of impact, but that impact is likely to be less. I think many of the humans in that situation choose the project or the program with the largest potential impact, even if it may have the drawback of being more difficult to deliver and a lower likelihood rating. And I think that's just a bias. I think that's where the optimism bias sits, because you could say the optimism bias sits on, well, let's go for the most likely thing, not the most impactful thing. I think the optimism bias is on the impact side of the equation. And that's why it's much more likely that programs promising significant improvements are more likely to go through. And I think there's also something related to the previous answer I gave about the news cycle and the timeline. So wanting to announce significant impact. So I think we do have some natural, if I might call them, mechanisms and biases in the system that mean that we tend to go for these sorts of programs. I think it's hard to get away from that.
That's interesting, thank you. Mary, would you like to comment on this?
Sure. My sense is that optimism bias pervades an awful lot of these programs, and it's partly because you have to claim that something is going to be successful in order to get the money and in order to make the business case. I also think that there's some solutions that are seen as being much more attractive than others because they're not boring. So an awful lot of what we need to do in the NHS is actually super boring. It's improving really mundane processes. It's improving administrative infrastructure. It's investing in staff. It's investing in training. It's doing things like making sure people have a toilet they can use and a locker they can put their bag in. And that just isn't attractive in the sense that it's not glamorous. It doesn't. It's no quick fix. It requires an awful lot of small things to be done. So I completely agree with Ron. Optimism bias is there in the sense that people are looking for impact, but I think optimism bias is also about hoping somehow, somewhere, there's going to be something that in one fell swoop is going to make all the difference. And it's been very interesting talking about with Ron about the infection example, because an awful lot of that was actually coordinating an awful lot of very small process improvements, coordinating an awful lot of boring things like making sure somewhere people had places to wash their hands and all that kind of stuff. And that's really hard work. It's really, really unglamorous. And it's the kind of thing that's quite hard to put a kind of headline grabbing case together on.
Yes, I'd like to double underscore that, Mary. In my view, quite simply, I think programs, by their nature, their mission-driven nature, they attract optimists. They attract people who are wanting to solve a problem and take a punt on a future that they're trying to create in a pilot situation or in a particular. And as Mary has pointed out, it's generally not easy because all the easy problems have been solved. We're just left with the really tough problems now. So yeah, maybe it's attractive to optimists, which I think is quite endearing.
That's brilliant, thanks. We have time probably for just one more question, maybe two. So Charles, could you talk about how you anticipate using knowledge and information specialists to underpin our work, not just with data, but also with knowledge and the teams, and being able to harness that from both UK contacts and internationally?
Yeah, okay. Well, I'll do it quickly, so that we might have time for another one. So I think, as the framework makes clear, evidence is really, really important in informing programme design. Like, none of these problems that we're trying to tackle in the NHS are brand new problems. People have tried to solve these things before. There's often a good body of evidence. I mean, not all of it very clear what exactly it means, but there's a good body of evidence. So I think, Mike and I, when we worked together on some of the new care models programme, we recognised that lots of the places were doing things like risk stratification and multidisciplinary teams. Some of the places were implementing as if they were the first people ever to implement them. There is a huge body of knowledge, not necessarily giving you a blueprint about exactly what works, but certainly telling you about things that probably almost certainly don't work. So avoid those. And then when you are trying other things, experiment with those and evaluate them. So I think evidence specialists have got a massive role to play in this, up front in getting the kind of programme theory as good as it can be and evidence-based.
That's brilliant, thank you. So for a final question, I wanted to just come to you all to reflect on the national programmes that might follow the 10-year plan, and any particular emphasis that you thought should be pulled out of this framework as we move into those national programmes that may come from that. Would anyone like to take that up first?
I'm happy to go first on that,
Right,
Sarah. An example of something that I think is going to require an awful lot of this kind of early design and planning work is the NHS app. It's being positioned as the digital front door. There's an awful lot to think through there, and there are an awful lot of both technical issues but also social issues to be resolved to do with equity, inclusion and so on. And I feel an awful lot of stakeholder consultation. So that would be my top choice for a 10-year plan programme that needs a lot of attention.
Great, thank you. Ron?
Yeah, thank you. And building from the conversation early on in the programme today about ambient voice technology, I think we, particularly from Stella, and I think the whole panel actually, we had a really compelling case for involving the entire delivery system in delivery of these sorts of policies. So right from end to end, and recognising patients as having a critical part in that delivery system. So for me, that's an area where broad involvement is really going to be required at the design stage to make sure we implement these technologies in the right sort of way. So that would be my pitch for an area needing attention, and I think enthusiasm that we already have. So let's build on that.
Thank you, Charles.
So I would say one that I see as kind of a kind of programme which is quite similar to some of the kind of nebulous ones that we've seen before have been neighbourhood health, and I think it slightly set some alarm bells ringing for me in terms of like just the kind of lack of very clear objectives, the lack of a real sort of problem statement and analysis of that problem. And also, you know, when I talk to people around the country, people interpreting it in very, very different ways. And there's nothing wrong with that if you're learning from those things and then trying to get to a kind of a better kind of understanding of what might be work nationally. But I do think neighbourhood health it'll be very interesting to see how that turns out. And I would hope that this framework could actually inform that programme. It's not too late.
That's great, thank you. So I'm going to wrap up there. Thank you to Charles, Michael, Ron and Mary for that conversation. And thank you to everyone who asked a question. That was really insightful and great to get your perspectives. We talked about multifaceted stakeholders, how they approached solutions and problems, some of the complexities of understanding those problems, and the art of analysis in moderating viewpoints. As the National Programme Planning Framework is launched, we can all see how it'd be useful to overcome challenges around some of these big topics that we've talked about today. I'll now hand over to Hugh Alderwick from the Health Foundation for some closing reflections. Thank you all for joining today's session.